Ryan Stanton here with ACEP Frontline, and today is a very topical topic. Probably if you watch any of the medical headlines, this is going to be taking up most of it, at least it has for the last number of weeks, and we're talking measles. And we have a panel today to talk about not only the disease process, a little bit of a refresher, but also a partnership with, does it go Visual DX or Visual Diagnosis?
Visual DX it is.
All right, that's what I like to hear. So a little Visual DX, and I know I got the right answer there because we've got the CEO right here with us. So first and foremost, I'm going to let you guys introduce yourselves, tell us a little bit about yourself, and we'll just kind of do a around the horn here. So Dr. Most, you can go ahead and start off with a little intro.
Hi there. Thank you, Dr. Stanton. My name is Zach Most. I am a pediatric infectious diseases specialist. I am an assistant professor at UT Southwestern Medical Center in Dallas, Texas. And I also have a role as the associate medical director for infection control at our local children's hospital here in Dallas. And so measles has very much been on our mind as we help to prepare to keep our population safe during this outbreak.
And Dr. Moon.
Hi, I'm Jeffrey Moon. I'm an emergency medicine physician, faculty member at University of Pennsylvania, one of the assistant CMIOs there too. And I am not an expert on measles, rashes, or infectious disease, and I need help because I'm thinking about heart attacks, strokes, and traumas, and yet here comes an ESI3 rash with a viral syndrome.
That's going to be perfect. I think that's a lot of us right now. We learned about the rash, but now we actually may get to see the rash, and it's not a rash we necessarily want to see. And as I mentioned, the CEO of VisualDx, and we'll talk about that in a minute. The floor is yours.
Thanks, Dr. Stanton. So I'm Art Papier. I'm a dermatologist whose career is really focused on information technology and clinical reasoning. And I've been to at least 10 or 15 ACEP national meetings as a dermatologist. And when I stand there at that meeting, I hear from emergency physicians things like, I hate dermatology. Oh, dermatology. I need some help with that. And so it's really a pleasure to be on this podcast because I love teaching dermatology to non-dermatologists.
And that's interesting because it's always some of the most popular talks we have at any conference we do are the rashes, the can't miss rashes or whoever interesting rashes, whatever it may be. And of course, rashes make fantastic visual clues for some of those poster contests as well. So the reason that we're here today was with Dr. Papier, Dr. Moon, Dr. Most. They were part of an ACEP webinar that took place recently, talking about the outbreak of measles, some things to look for, and this partnership with VisualDx about getting access and being able to use those resources. So, Dr. Most, I'm going to start with you because you got your infectious disease and hands down the busiest whiteboard on the screen anywhere that we've got right there, which suggests a lot of thinking's going on. So give us a little bit of breakdown of where we are in your viewpoint on measles 25.
Thank you. Yeah, so you talk about can't miss rashes. I think measles qualifies as a can't miss rash. And so I'm very happy to help to sort of get the word out and help everything I can do to make physicians around the country feel comfortable being able to recognize measles and manage it appropriately. So I'm sure everyone who is listening to this is aware that there is a rather large measles outbreak going on here in the United States. For some background on that, prior to the 1960s, measles was an extraordinarily common infection. It effectively infected every person in the country before they were 15 years old. And it is a respiratory virus that is spread through the airborne route, right? So when somebody has measles and they're contagious, they're coughing up these tiny droplet nuclei that have measles virus in it that remains suspended in the air, can stay suspended in the air for hours. And so all you have to do is be in the same room as someone with measles and just breathing, and you can be at risk for getting the infection. And then measles pretty much went away in this country pretty dramatically starting in the 1960s, and then eventually to this point that we got to measles elimination in the United States in 2000. And the reason for that is the measles vaccine. There's a live attenuated measles vaccine, which is part of a combination vaccine called MMR. This vaccine has been around since the 60s. And then a second dose of the vaccine was recommended in the 90s. And through vaccination campaigns, this effectively led to measles elimination in the United States. Elimination doesn't mean that there's no measles in the US. It just means that there's no sustained endemic transmission in the country. So that there are people that get measles when they're traveling abroad and then bring it back to the US. And occasionally you'll get secondary cases and some small outbreaks associated with that. There have been a few and far between larger outbreaks of measles since 2000. But what's going on right now is one of the largest measles outbreaks that we've had since that time. This started in late January in what's called the South Plains region in West Texas. And the outbreak quickly spread over the past 2.5 months now to many different areas within Texas and also to other states such as New Mexico, Oklahoma. There's an outbreak in Kansas right now too that is probably associated with this one. And all being said, I'm trying to keep up with all the information on this, and anyone who's listening to this it's already going to be a little bit out of date. But there are updates on this, coming out multiple times per week. But it seems like there's close to 600 cases in the United States that are just associated with this outbreak, and it keeps growing and it keeps spreading. New exposure events are being reported all the time. We had an exposure reported at a hotel just outside of Dallas this past weekend. So we're still seeing growth in the number of cases here, and so this has been a very concerning outbreak. In addition to the cases, we're seeing rather severe cases too. There's been 2 deaths of children been reported in Texas from measles since the outbreak started, as well as an adult in New Mexico who died with measles, although that case is still being investigated for the cause of death. So this is a very concerning outbreak, and it's something that we're doing our best to try and mitigate and prepare for.
So let's dive right back into that for a second, and because what are some of the statistics that we're seeing in terms of, because I think from what I've seen with statistics, it's just proving that vaccines work, and when we get smarter than science and make other decisions, that bad things tend to happen.
Yeah, so measles is one of the most contagious diseases that we know of. And the more contagious a disease is, the higher proportion of the population needs to be immune in order to prevent that disease from spreading. And so when vaccination rates go down, we expect measles to be the first vaccine preventable disease that comes back. And you can see CDC's got data on this. You can see trends in MMR vaccine coverage over time declining. The public health experts would say that you need to keep vaccination rates at least above 95% in order to prevent measles outbreaks. And that rate has gone down below 95% in many places in the country, including certain pockets in Texas where the vaccination rates are even lower. Where this outbreak started, there was a pocket of a community where the vaccination rates were even substantially lower than that. So these lower vaccination rates are what have led to a resurgence of measles. And even among the outbreak, you can see it where about 97 to 98% of the cases that are being reported are in people who are unvaccinated or in people who have the vaccine status whose vaccine status is unknown. So even, amid this outbreak, having MMR vaccine and being up to date with vaccine recommendations has been proven again to be very effective in preventing measles.
And I'll bounce back to you here in a little bit, because I've got a question. I was looking at it for a TV segment about, one of the biggest questions I always get is who needs to get a booster or rechecked or whatever it may be. So just think on that for a minute, because we'll get back to you here in a minute. Dr. Moon, so you're in a position like me, where you're in I'm in a community setting, minding my own business. Every once in a while, you gather everybody around to come look at the chicken pox that comes in, because it's so relatively unusual now. But now we have this potential, and especially with Dr. Most's area there, where there may be quite a number. Kentucky, we've only had 1 or 2, and those have been based on travelers. So give us a little background on your experience and how, technology that we have now can help you kind of re-up your game with regard to being comfortable with identifying measles if it comes in the door.
Yeah, so busy ED docs are focused on high acuity cases. That's what they're there for, true emergencies. And then, there's going to be a mid-track type presentation with probably a rash, a viral syndrome. We're still seeing flu B in Philadelphia where I'm at now and that kind of stuff. Could be seen by one of my APPs or myself. And I am not, unlike our guest today, a dermatologist or an infectious disease doc. But I'm probably the guy you're going to see because they don't come in, of course, wearing a diagnosis. So what do? I need a little bit of help for these rashes, and we do our normal emergency department workflows where we triage them based on acuity, ABCs, history, physical, and now we're at the point of like, even though it doesn't strike me immediately as life-threatening, what else can I do? This is where I personally, and I think I'm like most ED docs, I would like to do maybe use a tool, maybe use some software, maybe something on the computer in the clinical desktop that I'm using that is fast, it's easy. I don't really need much training for it. It's kind of inline and integrated with my workflow. This is what's I think pretty neat about as an ACEP member, I now have access to pretty much the premier dermatology infectious disease software out there, VisualDx, where I can think about, oh yeah, that patient in room 17, in my mind's eye, I can picture the rash and that kind of stuff. I don't know exactly what they have, but I have this external brain, VisualDx or whatever you might use, to help me figure out what this might be, what tests can I test, and then what are the next best steps.
And I think we all, at some point, whether it's the Google machine, Visual DX, or whatever it may be, trying to say, does it look kind of like that one? What do you think? Does it like that one? For us in the emergency medicine, I think it's one of the areas where we overall kind of, for some reason, gives us the most a little bit of indigestion is some of these rashes, because of course the vast majority are fall under the dry wet it dry it kind of mantra. But then you've got the ones that potentially are the pretty bad ones, and of course the ones that always are drilled into our heads are things like our infectious diseases, meningococcal meningitis, things like that, identifying those rashes. And that's where this technology comes in. So Visual DX and Dr. Papier, you give us a little background on where this came from, because as the dermatologist here, getting this out there, the information for other physicians and practitioners to be able to identify, whether it be rashes, whether it be just, dermatologic based presentations. Give us a background on the program and then how it ties into what we're doing now with measles.
Yeah, thanks a lot. So, around 30 years ago, when we still had this stuff called film, I know many of the listeners don't remember that, but VisualDx is headquartered in Rochester, New York, home of Kodak. Kodak had announced scanning film to digital, and I went to the chair of the derm department. I said, this is going to be huge. We're going to get rid of our Kodachromes, and we're going to have digital images on our computers. This is way pre-internet, and it's a long story, but we started developing the software at the end of the 90s, and in 2001, March of 2001, we launched it. And we had purposely chose the differential diagnosis of fever and a rash, because we know that most people think of dermatology as being a really lightweight thing like acne, psoriasis, eczema. People don't really take dermatologists seriously, right? So we said, well, where's dermatology serious? We said, well, in the ED, it's serious. And so we launched this in March of 2001, and we were way ahead of our time. And then what happened, of course, was 9/11. And then right after 9/11, anthrax was spread in the mail. And so VisualDx was discovered from a public health perspective back in 2001. We were supporting bioterrorism preparedness. And the tool has over 100 diagnoses. So, we're talking about, as you mentioned, meningococcemia, or vasculitis, or now things like cocaine levamisole toxicity or xylazine, that serious things in the ED. And so we've always had this focus of how do we improve diagnosis? And, patients don't come into the ED with the sign on the chest and say, I have measles. They come in and they have a rash. And you're trying to figure out, is it serious? Is it life-threatening? Or can I send this patient home? Does this patient need to be admitted? So we developed this technology around problems. So it's not only searchable by disease, you can search by clues. Like you can say it's a vesicular rash, it's widespread, and it's a fever. And you can enter any clues and get to possibilities visually. And then about 7 years ago, along came machine learning, where you can train imagery. And we have what we argue is the world's best collection of professional images, train machine learning algorithms on imagery. And so we've trained this algorithm on images of disease in light skin and dark skin. And we've been recognized as really developing equitable decision support so that you have a tool where you can see a patient with measles and feel like, for instance, you see a patient with a rash, they think they have measles in the ED, and the patient's arguing with you, and you're really busy. And they're really concerned that their child has measles. Well, you can open up VisualDx and go in the other direction and show pictures to the parent or the patient saying, this is what measles looks like, to reassure them and get them to back down from their certainty that they have measles. So we're seeing it in both directions right now. So, obviously measles is still pretty rare. Most rashes are not measles. And really the importance of what we're doing is we're covering everything. We're covering every derm disease, every serious derm disease that an ER doctor needs to know about.
So I take it you're not involved with a lot of standardized testing because those are always awful images. It's like the worst possible images ever. It's like an EKG taken from across the room kind of stuff. But where do you get these? How do you compile all of this stuff? I mean, unless you're the most unlucky dermatologist ever, who's getting an anthrax case walking through. How do you collate all of these types of images and pull them together?
Well, we've worked with physicians and departments over 30 years who we judge as experts and mavens in medical photography. So in your field, Dr. Larry Stack, who's just a wonderful ER physician and photographer, he's contributed images to the collection. And likewise, in every other specialty, particularly dermatology, we have relationships with departments, with individuals that are passionate about photography. And so and including ophthalmologists, we have incredible cornea images from experts at the Wills Eye Hospital in Philadelphia. And we've been systematically collecting imagery, not just to show the classic, but to show early presentations of the disease, show the variation, right? So one of my mantras is that variation of the common causes a lot more harm than missing super rare diseases. It's just math.
Yeah, completely agree. It's the common things are common, and it's these rare things like this, and that's why this type of discussion we're having, is important because we're now taking something that was incredibly rare and may become common, will be common for certain communities, certain emergency physicians out there, especially in West Texas. But now, something where we're trying to retrain our brain. So, this is VisualDx is available to everybody, across around the world, whatever. But this particular side is a partnership with the American College of Emergency Physicians as a member benefit. So talk about that partnership with regard to addressing measles in emergency medicine.
So we signed an agreement with ACEP to make VisualDx free for the next 2 months, with hoping that this outbreak will only last another 2 months. And any member of ACEP can get free access for 2 months, and then there will be a fee, a discounted fee after that for ACEP members. And we also work with institutions. I want to point out that departments and hospital systems license VisualDx and integrate it into the EHR. So this isn't always like an individual responsibility. The future of health tech is really seamless integration into the EHR. We going to see rapid advances now with ambient listening systems. And, there's just a toolkit of information that we have that we're trying to get out there. And so there's this literal treasure trove of imagery around the differential diagnosis.
And
So that's the important part of the story. I think, Jeff, maybe you can give kind of real world insight into that.
yeah, I'll just tell you, as someone who's thinking about, patients per hour and that kind of stuff, and getting the discharges and dispos and that kind of stuff. I need something as a busy ED doc that meets my needs of speed, of efficiency, and I need to really be able to understand what I'm looking at with sort of minimal training at times, in the sense of, because it'll be something that might be rare. When I read online on the CDC website or on other private vendors about, quote, a maculopapular rash that could be red or purple on the chest or the arms, could be palms and spiritual, my mind's eye can't picture anything. I'll admit it. I really struggle, and that sounds like about all the rashes. But when I see high quality images, I'm like, yes, this is what, again, Room 28 kind of has. And that's a little bit why I think VisualDx is a little separated from some of the other competition. As Dr. Papier was saying, that it's the number of high quality images that you can just fly through. And then not only do you see what you think the patient might have, you might learn that's actually not the disease my patient has. That looks different from what I've seen in the various ages, early, middle, late. It's got a whole differential of similar looking or similar demographic type patients with other diseases, slightly different. You just click through it, and it really helps that busy ED doc like me and others, and it's great ACEP is enabling it.
I like the fact that, with the more pressure that's on to see more, do more, weird environments in our emergency department, whether it's practitioners in triage, lobby, whatever it is, any tool that can help us with efficiency. And, before I jump back to Dr. Most while he's thinking about his MMR stability, I want to, you mentioned, Dr. Papier, you forefront with Kodak nearby. Interestingly, I grew up right near one of the Kodak plants in East Tennessee. You seem to be on that forefront for sure of the technologies, and you've already put in and mentioned the machine learning side of it. And of course, now what we're looking at is just this rapid expansion and involvement of AI. And how do you see that, with that machine learning AI components, really evolving the visual side of emergency medicine, and what you're trying to help us with regard to dermatologic manifestations?
Yeah, so we have technology now where you can take a photo and our app will guide you through the differential of 300 diseases. And it's very, very powerful, and AI is only getting better over time. But, it's not always answered through an image. Like if I show the best dermatologist or Dr. Most a picture of what we would call an exanthem or a morbilliform eruption that looks like measles, and it's just red, pink spots all over the body. And I said, diagnose this with no history. Just look at the rash and tell me what it is. Dermatologists or ID docs will say, it's just an exanthem. It's just a rash. I need to know, did the patient travel? Did the patient start amoxicillin? I need some history. So it becomes multimodal. It's not just the images itself, right? And so, medicine, sometimes it's pattern recognition, it's instant. You show me a patient, I look at it, I go, it's a basal cell, or that's probably a melanoma, or that's psoriasis. But that isn't always the case. The patient might come very early in the process. They might have, a fever, or, in the ER, people come in with chest pain. You rule out MI, and then 3 days later, they have zoster, right? They have the rash of zoster. So things fall out over time. And, AI is not a panacea for everything. We are using large language models in our research and figuring out what's the ultimate hybrid of large language models and our very, very clean data. But people have to realize that large language models are just an algorithm. and you can put in the exact same search into a large language model, ChatGPT or others, and then 5 seconds later get a different answer because it's all statistical. So you wouldn't want a different answer if you were the pilot flying a 737 every 10 seconds. You need high reliability. And this is really important, the word trust. You as an expert in the ER need tools that you can trust. You need to know this is not a deep fake. This is not some synthetic conjured image that isn't real. So we're really into taking advantage of AI, trying to speed up. Everything's about speed. How do we get VisualDx to be faster and faster? But we really want to maintain accuracy and trust.
And I think that's where we are with AI right now, at least with the current manifestations, is the fact that with us in emergency medicine is increasing efficiency, expanding differential diagnosis, giving us kind of that second brain to kind of look at some of these things and say, this, did you think about this? Because it's, you mentioned the pattern recognition, and there's things that as soon as they walk in the door, Bell's palsy, I'm going to turn them around and have them out the door in 2 minutes. And, whereas other things are a little bit more nebulous. So as we trust that it's prime time for infectious disease with Dr. Most and the pediatric side of things, you guys have had a big number of years over the last little bit with infectious disease. It's been prime time for you all between a pandemic and now measles.
Yeah, we've been center stage a lot recently. That's not always
Yeah,
a good thing.
not necessarily a stage you want. It's it's an off-Broadway play here. Did talking about what everybody's asking us, our patients are going to ask us their need or concern for measles, who needs to be checked, who may need another dose, whatever it may be. Kind of walk us through with where we are right now, who needs to be aware, get checked, get a dose, whatever it may be.
Yeah, this has been a very common question. And whether it's for a physician who's trying to come up with recommendations for their patients, or worried about themselves because it's the ED physicians who are going to be the people that are going to be most likely to get exposed to this. The best way to prevent measles is to ensure that you're immune to it. And there's various ways that we can confirm that someone's immune to measles. But it's worth pointing out that whether it's from infection or vaccination, you typically get a permanent lifelong immunity from measles. So anyone who's been infected with measles before, if you've had a confirmed measles infection, hopefully that's not going to be many of the people that are listening to this, but if you have permanent lifelong immunity to measles. Everyone who is up to date with their vaccine recommendations is for MMR vaccine is also considered to be immune to measles. For children, we vaccinate with MMR. We have one dose at 12 to 15 months old, and that first dose covers about 93% of people with, again, permanent lifelong immunity. And then we give a second dose at 4 to 6 years of age. And that second dose is not a booster. It is intended to try to capture some of that, like 7% or so who didn't respond to the first dose of the vaccine, and pick them up and get more people covered with immunity from the vaccine. And with the 2 doses, you're around 97 to 98% of the population, again, with permanent lifelong immunity. That's not 100%. There can be breakthrough infections after vaccination, but they are quite rare. And so anybody who is up to date with vaccine recommendations is considered to, for practical purposes, be immune to measles. I would not recommend going out and getting your vaccine titers checked. What you can check is your immunoglobulin G or IgG level to the measles virus. But if you know for sure that you're up to date with vaccine, you don't need to go ahead and get checked. So you can check your immune globulin status if you are unsure of whether you've had measles vaccine before, or there are certain people with immunocompromising conditions that it may be worth checking. But I want to try to discourage people who know that they've had their vaccines from going out and getting their IgG titers checked. It can be misleading. Sometimes those numbers can wane over time. The actual amount that you measure can decrease with time, but that doesn't necessarily mean you've lost your immunity. There's other aspects to immunity than just the amount of measurable anti-measles IgG you have in your blood. So to shorten the answer, the key here is staying up to date with measles vaccine recommendations. If you are up to date with your vaccine, you don't need to go ahead and get checked for titers or to get an additional booster. If you're not up to date with vaccine, or you're not sure if you're up to date with vaccine, then just go ahead and get a dose of the vaccine.
Joined today by Dr. Most, Dr. Moon, and Dr. Papier, and talking about the joint relationship between VisualDx and the American College of Emergency Physicians as a member benefit, but also a program that is available for everyone. It sounds like a fantastic piece. I'm actually about to have it pulled up here so I can give everybody the ACEP base link here shortly. But as we close up today, I want to kind of get any closing thoughts, anything you all want to plug in before we wrap up today, and I'll start with you, Dr. Papier.
One thing is Dr. Mose did an excellent overview of the clinical findings of measles, and I encourage ACEP members to view the video of the webinar that I think will be posted within a day or two on the ACEP site. The program is at acep.org/visualdx on the ACEP site. And, as I said earlier, this is not just about measles. This is really about pattern recognition, improving the ability of the busy ER doctor to have the right information at the right time, at the right place around skin presentations broadly. Measles is one of them, but we can help you broadly with concerning rashes in the ER.
Dr. Moon.
We couldn't possibly know all the stuff we need to about every case that walks in the door in the ED. And we all have our sort of reliable external brains. That there's weird EKG presentations, CT abdomen pelvis reads of things you've never heard of. We're always looking stuff up. Derm in particular is a visual diagnosis. It's a visual disease pattern largely. And so you really want to have a good resource for those tough cases, especially if you're in a place where measles might be spreading. So VisualDx is a great option for you, and I know I'll be using it myself.
And finally, Dr. Most.
Yeah, thanks. So, other than, vaccinating and keeping yourself protected, the most important step that doctors can take to help in the setting of an outbreak is to familiarize themselves with measles, to recognize early when someone has measles, so you can take someone who's contagious and move them into a place where they're not going to infect as many people. From the public health standpoint, identifying these cases so they're not then, traveling on planes and crowded areas and spreading the disease further. So early recognition of measles is crucial. And I can't think of a better tool to help with early recognition of measles than something like VisualDx, which actually shows you images of what the rash looks like. And so I highly encourage ACEP members and anyone else to use these resources that are available to familiarize yourself with what measles looks like and be able to diagnose it early.
I encourage everybody to check it out. You can just throw in your favorite search engine, ACEP and VisualDx, and you're going to get right there to it. Once again, it is a free member benefit for the next 2 months for members, and then a discounted fee after that. But again, a program that is available for everybody, even if not a member, with regard to a resource to help with those visual diagnoses. And I appreciate all of you guys, your flexibility to be able to all come together. Having 4 physicians come together on pretty short notice is always a little bit difficult. So I appreciate everybody's flexibility, especially on an evening like this, when it could be more down to Miller time at this point for some of us. But appreciate you guys coming together, and thank you for everything. And invite once again everybody to check that out, this partnership. Hopefully we're going to get through this pretty quickly, and Dr. Most and the rest of his infectious disease physicians can go on the back burner for a while, maybe a little less boring, a little more boring with regard to our infectious diseases out there, but it's something we're dealing with now. I expect to see some decent numbers coming through. So until next time, you can join me with the podcast. Make sure you like every episode and share it. You can join us on the ACEP Frontline page on Facebook, as well as at Everyday Med on X. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.